VServe presents Know Your Health, a podcast that brings you experts in healthcare talk about specialties like never before. Stay tuned. Being in the healthcare industry for over 2 decades now, I have interacted with a lot of healthcare professionals and surgeons. Well, I've come to a realization that surgeons are creative. One such surgeon that we are going to interact today has time and again validated this thought of mine. He's a surgeon with over 15 years of surgical experience and has operated over 5,000 patients. His perspective in story articulation is unconventional and gripping. Please welcome Dr. Mazda Turel.
It's my pleasure, entirely my pleasure. Thank you for having me.
So, while we've had so many conversations, there has been this one question which kind of reverberated for a longest time but never really surfaced. But I think let me take an opportunity to ask you this question. Well, I've always observed that most neurosurgeons are spine surgeons. That's a question. And why aren't all spine surgeons neurosurgeons, despite of spine and brain being a part of our central nervous system? So is there a reason or it's a matter of choice?
So, that's a good question actually. There's a lot of dilemma minds of people also as to who they should visit if they have a spine problem. And there are two broad categories of surgeons that do spine work. One is neurosurgeons and one is orthopedic surgeons, primarily. So, neurosurgeons do surgery on the brain and the spine. That's part of their training. Orthopedic surgeons, some part of their training involves spine surgery.
Okay.
But those surgeons who go on to specialize in spine surgery call themselves spine surgeons. So they primarily do spine surgery, then probably some of them let go of, let's say, hip surgery, knee surgery, all the other bone and joint surgery, and then they focus on spine surgery.
Okay.
And that's what makes them spine surgeons. Wow. But they don't do brain surgery. So that's how they have coined the term for themselves as spine surgeons, and they're exceptionally good at it. They primarily do work on the spine that involves bony structures, that involves things like slip disc, degenerative spinal problems. If you have a tumor within the spine or the spinal cord, then it's primarily a neurosurgeon who will do it.
Okay.
But there is a gray area and there's a little bit of overlap, but it makes no difference if you have a spine problem, whether you go to a spine surgeon, an orthopedic spine surgeon, or a neurosurgeon. They'll probably give you more or less the same kind of treatment.
Oh, that's actually an insight for me. In fact, I was thinking whether or not these two symptoms for spine and brain, are there any correlated symptoms which a patient complains of, which may or may not be related to, let's say, for example, if someone's having a neck and headache, will it be related to spine and brain or either or? So the correlated symptoms, are there any? And if, what do they indicate?
So, just take something as simple as difficulty in walking.
Right.
Difficulty in walking can come from a back issue, can come from a neck issue, can come from arthritis of the knees, can come from a brain issue. Sometimes you have fluid accumulating in your head, sometimes you have a tumor in the frontal lobe. So a very thorough clinical evaluation needs to be done as to what is the neural substrate of that difficulty in walking, or what is the anatomical substrate of why a patient has difficulty in walking. And then further imaging or evaluation is targeted towards what your clinical findings are. So of course, sometimes there's an overlap. Like you mentioned, neck problems. You can have migraines related to neck problems. You can have sleep disturbances related to neck problems. You can have postural effects related to neck problems. So a very thorough clinical examination is paramount before you can come to a conclusion as to what is the root cause of this person's problem. And both a spine surgeon and a neurosurgeon can make that evaluation. And sometimes orthopedic spine surgeons, if they find that there could be a neuronal involvement, then they would refer the patient to a neurologist or a neurosurgeon to seek some kind of advice on seeing if what they think is the right thing to do.
Okay. So let's say a lot of patients probably are undergoing medical management or physiotherapy or certain kind of medication constantly for the backache, spinal ache, or maybe a headache. When does one see a surgeon? If it's a simple question to answer, or maybe it's a complex question. How?
No, it's very simple. So let's say you have a slip disc or a herniated disc or some kind of spinal stenosis that doesn't seem to get better with 4 to 6 weeks of medication and physiotherapy.
Okay.
That's when you see a surgeon. Because you've tried more or less all the conventional routes. Surgery is usually reserved as a last resort.
Okay.
The option of taking an injection exists, the option of changing medication exists, the option of doing all those things exists. And if you've exhausted those options, then surgery sometimes comes to rescue.
Okay.
Oftentimes, patients don't want to wait for that entire gamut because that process may be long and they say, listen, I want to just get it done with. And that may also be something that you would want to discuss with the patient before going ahead with surgery.
Okay. Another common problem is headaches, is what we find everywhere today, and majorly because of the screen timings today, the use of headphones, cell phones. Headaches are pretty common, and most of them term them as migraines, sinusitis, something like that, and they self-diagnose mostly. Where and when does one feel that okay, this is something serious? How does one come to a point where they just say that let's just get investigated? So when should that happen?
So, if you have a sudden onset severe headache, which is the first time you ever had a headache, it has to be investigated immediately, no waiting. Get a CT scan or an MRI, find out if there's an aneurysm rupture. But that's rare. Most headaches are subacute or chronic headaches.
Okay.
If you have a headache, let's say for about 1 or 2 weeks, that's not going away, you should 100% get an MRI done, no questions asked. In that 1 or 2 weeks, you rule out eye problems because a refractory error is a very common cause of headache. You rule out sinus problems. You rule out tooth problems. Sometimes impacted teeth can cause headaches. You rule out jaw problems. Temporomandibular joint arthritis can cause headaches. Ear diseases can cause headaches. Arthritis in the neck can cause headaches. Obstructive sleep apnea can cause headaches. So if you've quickly done a screen and ruled out all of those things, and you still have a dull aching headache that's not going away, your symptoms are not very typical of migraine, then you get an MRI done. I see several patients a year who have brain tumors, and the MRI is primarily done to rule out a brain tumor. I see several patients a year who have brain tumors, and all they have is a simple dull aching headache that doesn't go away. So, also if you have a headache associated with vomiting, double vision, any weakness of the hands or legs, any neurological dysfunction like loss of hearing, visual dysfunction, there's no question asked. You have to get an MRI done. I have a very low threshold of getting an MRI done. So you have a headache, it's not going on, get an MRI done. If the MRI is normal, then you do whatever else you want to do to take care of that headache symptomatically. You make a more neurological diagnosis, you see if this is migraine, try a treatment, therapeutic treatment for migraine or whatever else that headache might be, depending on, it's a very broad umbrella headache, and it needs to be assessed in slightly more detail to be able to give it a proper term and then to treat it accordingly. So once you have an MRI, at least you know that you're not missing anything that is structurally reversible. So basically, primarily, you just want to rule out brain tumors or any structural pathology that could be responsible for the headache.
Okay. Speaking of MRI, I think most patients fear MRI because of probably the lengthy process, or they term it as a major investigation. We don't get an MRI done on a routine basis. A simple blood test, of course, even if the name or the test is bigger enough, it's just a blood test. They will term it as just a blood test, so might as well get it done. MRI has a process
Yeah.
plus the duration of MRI. I think that has primarily led to people avoiding MRIs that sooner, unless it's very, very major, is what I've observed in a lot of patients that I've been interacting. In an international setup, it's much easier to tell them, let's get an MRI done, and then they just say, okay, no, yes. Here they want to get an X-ray done first,
Yeah.
and then see if, you
Right.
know. So how do we close that gap? Is there a way to close that gap, or we just
You have to counsel them adequately and tell them that I think that this is absolutely necessary. Nowadays, an MRI is available at every corner of the road.
yeah.
So it's not. And now also, some people don't want to get an MRI because they feel claustrophobic. We have certain centers in the city that have an open MRI machine. That's also possible. Now the time also to do an MRI, mostly for a brain protocol, doesn't take more than 20-25 minutes. And they have noise cancelling headphones. They play some beautiful music in the machine. They've given you some scenery to look at if you need to. So there's several things that they've modified now to make the MRI experience not as dramatic as what it used to be. And otherwise, if you are in the machine, it feels like construction's going on. But you're living in the city of Bombay, I think you're used to that sound.
Okay, so speaking of MRI, what are the most complex brain surgeries that you have operated or you've done so far? Or maybe one of the surgeries, if you think you have involved your approach and expertise differently than usual brain surgeries.
So we do a lot of complex surgeries that, and they're primarily brain tumors. And sometimes they are situated right smack in the center of the brain. Sometimes it depends on the location. Sometimes they are surrounded by large blood vessels and cranial nerves. Sometimes we do combined surgeries with ENT surgeons where we operate on brain tumors through the nose endoscopically, large tumors. And so every tumor, depending on the location, has a anatomical challenge. And sometimes the difficulty in surgery lies primarily because of the consistency of the tumor. You know, sometimes deep tumors also, if they're soft and suckable, they come out easily. But sometimes tumors, the firm, hard, fibrous, vascular tumors. So it's very difficult to tell you classically what's like the most challenging case. But oftentimes, tumors in difficult locations surrounded by arteries and nerves are the most complex tumors to be able to excise from the brain. And sometimes they can take long hours, they're exhausting. Most often, brain tumor surgery takes anywhere in the range of 2 to 4 hours. But sometimes these tumors last 6 hours, 8 hours, 12 hours, 14 hours. You do have those cases, and those require a lot of focus, a lot of persistence, a lot of tenacity to be able to go through that without, giving up.
I was going to ask you, while you operate on a tumor, and when you decide on a brain tumor surgery, when does a surgeon say that no, we should not operate this kind of tumor? What is that? How do I say this? When does the surgeon refuse to operate on a brain tumor because of the pathology or the location of the tumor?
So primarily, in conditions called as glioblastoma multiforme, which is a stage 4 brain cancer,
Okay.
and if it's recurred twice or thrice, you know that the survival is not very long, just a couple of months. Even excising it is not going to give you a good satisfaction because it's going to come back within a couple of months.
Right.
Those are the times when you persuade the family from not wanting to have another surgery.
Okay.
Sometimes there are tumors that are benign in nature and that are not doing anything to the brain,
Right.
and are sometimes incidentally detected. You do an MRI for something else. Let's say someone's had a fall, get an MRI done, you see a tumor sitting over there. and it may not cause any problems to the patient. Those tumors also you can watch and observe rather than jumping into operating on them. So these are the situations in which you might see a brain tumor, but you might not do anything about it. Or sometimes you may just have a benign tumor that's diagnosed because of, let's say, some symptom like a mild headache, but you know it's a small tumor, you know it's benign based on the radiology. Let's say patients in their 80s or 90s, they might outlive the tumor themselves. So in those conditions, we might offer them just an observation strategy.
What are the most critical signs and symptoms that one should not avoid or one should not neglect in the area of your expertise?
So like I mentioned to you, if you have a headache that's not going away, you should get an MRI done. In the elderly people, if they have forgetfulness or behavioral changes, or let's say the so-called psychiatric symptoms of excessive anxiety, depression, all of these symptoms can be because of a tumor in the brain sometimes. And one should always, before starting on medicines for dementia, one should always get a scan done.
Okay.
That's very important. Those are the two primary situations in which I insist on getting an MRI. Otherwise, your body will tell you in terms of symptoms. If you have difficulty in vision, you'll get a scan done. If you have a hearing problem, you'll get a scan done. If you have imbalance while walking, you'll get a scan done. If you have neck pain or back pain, which is not getting better with medicine and physiotherapy, you'll get a scan done. So those are the conditions in which you must insist on getting an MRI done to be able to... See, my funda is very simple. You should rule out any structural pathology in the brain or the spine if you have symptoms related to that.
Okay.
Once you rule out a structural pathology, you can easily manage everything else. At least you know that you are not missing something that's reversible to treat. It's as simple as that. So most conditions in today's day and age should be classified as MRI positive and MRI negative, and then you treat your problem that way.
So in both the situation, either spine or your brain, MRI is something which gives you a clearer picture.
Yes, 100%.
So someone who has been experiencing certain complaints related to spine or neurology, they should definitely get an MRI done if it's prolonged for a period of time.
Yes.
What are the types of neurology conditions that you most frequently treat?
So symptom-wise, it's mainly headaches, neck pain, back pain. Pathology-wise, it's primarily brain tumors for the brain. A lot of vascular malformations of the brain, such as aneurysms, arteriovenous malformations. We do surgery for epilepsy, for patients who have seizures. Other conditions for the brain that are treated are conditions like hydrocephalus, where there's water that accumulates in the brain. Trauma, all kinds of head injuries. If patients have bleeds in the brain, either from hypertension or from a subarachnoid hemorrhage, those are the conditions that we treat. And in spinal pathologies, we treat primary conditions like slip discs or herniated discs, degenerative problems of the spine, spinal stenosis, which is compression of the spine, spinal tumors, spinal trauma, spinal infections. Those are the spectrum of pathologies that we treat in the spine. And then peripheral nerves, which is also part of the central nervous system, common condition called as trigeminal neuralgia. Carpal tunnel syndrome. Trigeminal neuralgia is another condition which is related to the brain, where patients have sharp shooting pain in the tooth or the jaw, and we treat that also. So the entire spectrum of craniofacial pain syndromes is again treated surgically to some extent.
You mentioned spinal stenosis. So spinal stenosis and slip disc, are their symptoms common? I mean, the diagnosis is...
Correct. So the symptoms overlap.
Right.
So basically, spinal stenosis is when your spinal cord gets compressed by thickened bone or ligamentum that's pressing against the nerve.
Right.
Slip disc is again the spinal cord, the nerves are getting compressed either by a disc that's pushing against it. So the pathologies are different, but the symptoms are more or less same. Most people will have back pain, leg pain, which we typically call sciatica, or something called as claudication, where patients can walk for about, let's say, a certain period of time, and then they start feeling heavy in their legs get numb, they need to sit down. Sitting down relieves the pain for a bit, and then they can walk again.
Right.
So these are symptoms of lumbar canal stenosis, any form of stenosis. The stenosis can be compression from the behind, compression from front. Bottom line is that the nerve that's supplying the lower limbs is getting obstructed, and that needs to be relieved.
Okay. So do minimally invasive surgeries help in such conditions?
100%. So depending on the pathology, minimally invasive surgeries, in my opinion, and I may be biased, can deal with up to 80-90% of spinal pathologies. And nowadays, with the advancement of minimally invasive techniques, with the introduction of the endoscope, we're able to do more of these with smaller incisions, lesser invasion of muscle, lesser damage to bone, preserving important structures in the spine, lesser destabilization of the spine. Infection rates are much lower. Patients get mobilized within a couple of hours after surgery. They can go home the same day or the next after surgery. The post-operative outcomes are greater. Their post-operative pain is much less. So there is a lot of advantage to doing stuff minimally invasively. You're doing a lot less disruption to normal anatomical structures to get to the main point of pathology. That's the only advantage that you have.
Sure. What about robotic navigation systems? Are these different techniques than minimally invasive surgery?
No, they are just an added armamentarium to the tool of minimally invasive surgery. So minimally invasive surgery, you could put in, let's say, screws into the spine using X-rays and or navigation. And now you have an additional arm of the robot that can help you do the same thing, which improves precision by a couple of millimeters. So in selected cases, it may be of great value.
Okay. So does open spine surgeries are going towards being obsolete or?
No. See, open spine surgeries actually have stood the test of time over several decades. And they've resulted in great outcomes. And people who had open spine surgeries 20, 30 years ago are still completely, many of them are absolutely fine. So it would never become obsolete. It definitely has its role. And in certain conditions, we still need to do it, depending on the kind of pathologies that you treat on a primary basis. If you're a scoliosis surgeon treating bad curves, etc., you will have to do open surgery more often than not. So it has its role, but there is more and more stuff that we can do minimally invasively and get the same result.
Okay.
So open spine surgery is not going to become obsolete. Also, the technology and the gadget and the tools required for minimally invasive spine surgery are not available everywhere. So open spine surgery still serves as a very good method to deal with many, many pathologies.
Okay. So a typical spine surgery, what does a recovery, post-op recovery looks like?
Let's say if you take but if you take a typical case of a slip disc or a herniated disc or a disc prolapse, if we operate the day of surgery, patients are walking within a couple of hours after surgery. Typically, more than 95% of patients say that they have complete relief of pain, primarily in the leg. A little bit of back pain persists at the incision site, and usually that takes about a couple of weeks to go away. But most patients are happy to resume work by the end of week 1 of surgery. If you have a slightly more extensive surgery where you've put in some screws and rods, patients take about 2 weeks to get back to work.
Okay. In case of fusion, when we decompress and fuse a spine and it's at most of the levels, let's say, then the mobility of the patient is compromised.
Correct. So fusing itself means that you are restricting movement, right? So if you do it at 1 or 2 levels, it really doesn't make a big difference. We still have patients who have had fusions at 2 levels and are running, jogging, surfing, biking, doing everything that they have to do. if you do a very long segment fusion, it does affect mobility a bit. So let's say if you do 7, 8 levels, it'll definitely affect mobility a bit. But still, nonetheless, they're still able to do a lot of the stuff that they wouldn't have done if they didn't have the operation.
Right. So how do we ensure, mobility in patients who've had partial paralysis, wherein they are currently undergoing physiotherapy and occupational therapy rather? Is there any surgical offer that we can give them in terms of being mobile, or is there no chance of recovery in such patients who are partially paralyzed?
So if there's a partial paralysis, there's always scope for recovery.
Okay.
Because if there's some function left, we can always build on it with additional exercise, physiotherapy. You have some stuff you can do with robotics. You have calipers that you can wear. You have an exoskeleton now that you can put on, and that will help with the mobility. Depending on what kind of dysfunction you have, there are other tools. If you have too much of spasticity in your legs, you can insert a baclofen pump, or you can give Botox in the legs. You can do all of those things to see how best mobility can be optimized, if not restored. So a lot of options are available for us to help patients to some extent, at least.
So can we give, let's say, a percentage, or let's say if a person is having a right side paralysis, complete right side paralysis with no limb movement, no finger movement also, but over the period of time, if he or she does physiotherapy, are there any 20-30% chances of they being able to at least having a grip or some kind of mobility?
So a lot of this depends on the nature of the insult,
Right.
whether it's a infarct, whether it's a hemorrhage, how much of the brain is damaged, what is the age of the person, what is the extent of the damage. In children, a lot of normal brain takes over the function of the damaged area, and there's a lot of neuroplasticity that happens, and they tend to recover much more than the elderly if they sustain this kind of a damage. So it depends on the age, depends upon the location of the insult, it depends on the extent of the insult, and it depends on how aggressive you can be with the physiotherapy, with additional forms of therapy that can help mobility for the patient.
So technically, we can try different forms and then see what works best for the patient. But then if that's the case, then who does the patient consult? So does he consult directly a neurosurgeon, or because such cases are consulting consultants, neuro consultants?
So a neurophysician or a neurosurgeon would be able to guide them to the appropriate place for, let's say, rehab or for other forms of para surgical therapies that would help such patients in need.
In fact, speaking of disabilities in neurological cases, wherein in case of one dementia patients, in case of involuntary spasms, in case of speech difficulty, deep brain stimulation surgeries, how important would be an installation of such device in such cases where they have neurological deficits, and what is the longevity of such installations, wherein of course these are chargeable devices, but then what are the risks involved when it comes to such surgeries, and how better can a person's life turn from A?
So deep brain stimulation is a form of treatment where you insert certain electrodes in certain nuclei of the brain to kickstart whatever is not working. It's primarily used in conditions like Parkinson's disease, where patients have a tremor, slowness in walking, difficulty in movement. It's also used in other conditions like obsessive compulsive disorders. It's been tried in other conditions like depression, severe depression, schizophrenia, and the scope in other various mental health conditions is increasing. It's also tried in a gamut of other movement disorders called as essential tremors, dystonias, and the outcome primarily depends on the indication that has been selected for the patient. So you have to very, very wisely make sure that your patient selection is absolutely crystal clear before you decide on whether this is going to help this patient or not, because that is paramount. And there are many technical criterias that go into choosing a patient, and it might not be, it's very scientific to talk about it
Right.
for the layperson,
Right.
because sometimes neurologists and neurosurgeons themselves don't understand it.
Right.
And also there's a little bit of gray area and a little bit of overlap between who the ideal candidate might be for these conditions. But the complication rates are not very high, in the range of 1 to 2%, like they would be for any brain surgery. And in correctly selected patients, the outcomes are great. Patients go from being completely dependent to being completely independent, living good quality of lives for extended periods of time. And with newer devices coming in, the outcomes and the longevity of these devices seems to be more. And also the spectrum of indications seems to be getting more and more expanded. So functional neurosurgery, I think, has a very bright future in dealing with a lot of physical as well as mental health issues in the long run.
So when you say that we don't, we have to select and we have to be aware of whom are we going to administer such surgeries or recommend such surgeries, we are not recommending these surgeries upfrontly because there are so many cases.
Criteria. There are certain clinical criteria that you need to fulfill
Okay.
to be able to, because let's say Parkinson's also. Parkinson's has various varieties of Parkinson's.
Right.
There's atypical Parkinson's. There's other many overlapping conditions of extrapyramidal disorders
Right.
that may not benefit from deep brain stimulation.
Okay.
There are many clinical symptoms of a patient that will not get better with deep brain stimulation. So we need to understand the ideal patient, and if that patient fits into all your criteria, you offer that operation to this patient.
How do you decide between conservative management and surgical management?
For what condition?
Any conditions that, so let's say any spine conditions where patient comes in with complaints and it's a prolonged complaint and the pathology says that it's a stenosis, the pathology says that it's a herniated disc, but people fear surgeries.
Yes.
People fear surgery, they just don't want to go under the knife. And at what point do we say that this is it? I mean, you have to have.
So the indication is very clear. If you have a neurological deficit, let's say if you have a foot drop, or you have problems with bowel, bladder, bowel, sexual function, if you have severe numbness, what we call as cauda equina syndrome, there's no doubt that you need surgery, because that's causing permanent damage to your nerves. If pain is the only complaint, and that is causing most of the disability, then pain can be managed with a combination of medication, injections, physiotherapy, etc. I usually tell patients that you try everything that you think you want to try.
Okay.
Acupressure, acupuncture, cupping, needling, Baba Ramdev, whatever you want, you try all of that stuff.
Okay.
Once you think that you've tried it and you're not still happy, or it's still continuing to affect your quality of life, and the MRI is indicating that your problem corresponds to what you have, then surgery seems to be a good option to consider to be able to alleviate your symptoms. It's as simple as that.
Okay. But then don't we say that surgery gives you a better quality of life?
Yes.
We don't have to come back to the pain again and again.
Correct.
Wherein while we are doing conservative medical management, we are coming back to the pain.
It depends. A lot of people, if they're diligent with their exercises, see, you have to understand that most back problems happen because of weak muscles.
Okay.
and weak muscles of the core, you have to think of your back as a barrel. It's not just the back. So the back is the front, the back, the sides, the top, and the bottom. So all that musculature needs to be strengthened. And people who are dedicated towards working on it, 80-90% of them manage to become pain-free.
Right.
What happens with most people is that they exercise for a bit, they get pain-free, they stop exercising.
Okay.
And that's why the pain recurs. Or they don't follow mindful posture habits.
Right.
They misuse the spine. They do stuff that's, everyone's on their phone 24/7 now. Obviously, that adds to wear and tear on the spine. So if you're able to maintain muscular strength around the core
Right.
and keep your spinal muscles engaged and strengthened, there's a high chance that it's not going to skyrocket into a host of other pathologies.
Right. Okay. What is the difference between dementia and Alzheimer's?
So dementia is a umbrella. It's just another name for forgetfulness.
Right.
And in that umbrella, there are different categories of forgetfulness. So dementia, Alzheimer's dementia is one type of dementia. Frontotemporal dementia is one other type of dementia. Lewy body dementia is another type of. So they have several other types of forgetfulness, and each of them present with a different pattern. And there's honestly not very much that you can do differently because there's no medicine to really reverse it.
Right.
It's just that if you're able to diagnose the dementia correctly, your with a neuropsychological evaluation, your neurocognitive therapy for each of these dementia is slightly different and slightly more tailored and slightly addresses the problems that a person is facing individually rather than doing exercises for anybody who has dementia. So these are different categories of dementia that fall under this broad umbrella of forgetfulness.
Got it. So is there something that someone can diagnose way too early and prolong the
Onset.
onset and deepening dementia is what I mean.
Yeah, so some form of neurocognitive therapy, once you start forgetting stuff right from your early 40s, the bottom line to prevent all of this is to keep yourself physically and mentally active.
Okay.
So it's important that you stimulate yourself mentally by doing crosswords, sudoku, playing mind games, brain games, use both your hands to try and do stuff all the time, use your non-dominant hand to do stuff more often. Exercise is extremely important. You have to get in some amount of physical activity during the day. Sleep is paramount important. Your diet, avoiding saturated fats, eating the right kind of food. All of those things are extremely important in going ahead with degeneration of the brain and preventing degeneration of the brain. Avoiding alcohol, smoking, drugs, all of those things probably will help delay the onset of dementia.
But how do you pick a person that, okay, this person is moving towards dementia? Is there any?
With an early neuropsychological assessment, there's a battery of tests that you can do.
Okay.
And you'll get diagnosed with the initial stage, which is called as mild cognitive impairment. And then you can direct treatment towards it and see if you can help prevent it from progressing.
Okay. And which is, let's say, we diagnose something. Let's say we diagnose that this person is prone to have dementia in future. And like you said, like you mentioned about stimulating your mind and, being active per se. Is that the only precaution or that's the only regime that someone follows to be able to prolong dementia for the longest time?
Yeah. I mean, physical and mental activity is very underutilized.
Okay.
90% of people have sedentary lifestyles.
Right.
and that is why the incidence of all of this is increasing. But it boils down to something as simple as that. You increase blood flow to the brain on a regular basis, you prevent all of this from happening.
Basically, stress, what does it do to your brain, and does stress in any way lead you to some extreme neurological conditions which may lead to surgery?
I mean, stress is such a vague term, right?
Yeah.
Everybody talks about it.
Yeah.
There's no real way to measure it except for checking your heart rate variability. You can do some hormonal assessment, you can evaluate your cortisol levels, you can do all of those things, but more or less it's still quite vague. And it causes anxiety, it causes depression, it causes other forms of mental health issues. I don't think it probably leads to wanting to get surgery done in any way, but I think some form of practice of mindfulness might help people relieve it or deal with it.
Okay.
And again, it's a very individual.
Right.
It's very multivariate.
Right.
So there's no real way to. I mean, who doesn't have stress living in a city like ours, and the kind of lives that we lead, which are so fast paced?
Yeah.
It's very difficult to really put a finger on it and how to deal with it. And if you basically follow the tenets of daily exercise, eating good sound food, sleeping adequately, avoiding processed food, then I guess you'll be okay.
I'll tell you why I asked this, because stress, most patterns in stress lead to headaches. There are certain headaches associated.
This is called stress headaches. They're called tension headaches.
But then does this, when prolonged for a ample amount of time, does it change the pathology of the brain? Or
I mean, it definitely must be causing some structural changes in the brain. Prolonged stress definitely causes changes at a microcellular environment level. And people have studied it. Physically, you might not really see much of a difference. But it's definitely altering brain chemistry to some extent, for sure.
Okay. So, having heard so many of your stories that you share, and you have a very different way of articulating patient stories, and you pick certain perspectives and deliver it so well that the story becomes so interesting. While see, we don't want to hear medical stories per se, but when it's delivered in a way that you make it interesting, can you mention one of the cases that you found interesting while the patient walked in and walked out of your consulting room?
I mean, every day we have a story to tell.
Okay.
So, in just a couple of days ago, we operated on a lady in her late 70s who had a tumor exactly smack in the speech area of the brain. And she was finding it difficult to articulate, she was confusing words. There's severe, the family was not able to understand her. We got an MRI done, which showed a tumor sitting right there, which completely corresponded with why she had that problem.
Right.
And we went ahead and did surgery for her. And the pre-op planning showed that the speech area was completely displaced by the tumor behind, it wasn't infiltrated.
Oh.
So we were able to remove the tumor completely, relieve all the pressure effect on the speech area. Right. And then just a couple of hours after surgery, her speech was back to completely being coherent and speaking absolutely articulately. And so those are happy outcomes. And
Wow.
so, I mean, every day there's a story. We had a lady once with another brain tumor who came with us with a seizure.
Okay.
And it was in the language area again. And when she had a seizure, she completely switched from having never spoken a word of Hindi in her life to just talking in Hindi. All her life she spoke in Marathi with the family. She was a Maharashtrian lady. Okay. They've never spoken to her in Hindi, barring the few Hindi words that we use in our day-to-day language. But she never spoke a word of Marathi after the seizure that she had. And a couple of days later, we operated on her, removed the tumor, and she went back to speaking Marathi. So
This is crazy.
So there's a lot of stuff that we still don't know, a lot of semantics that happen in the brain, a lot of networking, a lot of language function, a lot of all sorts of other functions. We operate on tumors that are deep-seated in the brain. We operate on tumors that are superficial. We operate on large tumors, small tumors. There's a whole host of spinal pathologies that we operate on. Sometimes, so many times, people are misdiagnosed.
Oh.
With like you said, right? So we had a patient who was misdiagnosed to have Parkinson's because of the way he was walking. But when we evaluated him, we found that his walking is not because of Parkinson's, but because of compression in the neck. And we relieved that compression. And within a couple of weeks after surgery, that patient was walking as if he didn't have a problem ever.
Wow.
So, I mean, I can go on and on. Every week,
Sure.
I write a story about a different patient. And it's just fascinating to, just when I think that, I've exhausted the possibilities of every single diagnosis that exists as far as the brain and spine is concerned, we still find a different perspective to talk about. It doesn't always have to be about diagnosis. It always doesn't have to be about treatment. Sometimes it's about emotion. Sometimes it's about what patients feel, what they think, what their fears are, what they want from life, what their ambitions are. How is it to be diagnosed with a brain tumor? What are the thoughts that are going through their mind? So it's a gamut of, you're dealing with every single emotion, every single sense, for that matter. So there's a lot to discuss, and there's a lot to talk about, and there's a lot to make the general public aware that surgeons are also humans, and they go through the exact same feelings and have the same fears and have the same emotions that patients do.
Yes. Speaking of emotions, while operating a brain, have you noticed that you've taken out an EQ or an IQ of the patient post-op? Have you encountered that?
Oftentimes, after we do brain surgery, when we remove large chunks of brain, let's say there's a big tumor in the frontal lobe and you have to do what is called as a frontal lobectomy. Patients, when you look at them and talk to them, they feel as if nothing's wrong with them. But the family will tell you that he's not the same person that he used to be.
Really?
Yeah. So something's shifted, something's moved. So obviously, areas of the brain that we think are seemingly non-eloquent or seemingly not responsible for too much function, or being infiltrated by tumor and the function is disrupted, those patients we definitely affect EQ, IQ to some extent.
Okay.
Even though when you look and talk to them, they might seem absolutely normal.
Okay. Interesting. That's very interesting.
Yeah.
So while while as a surgeon, you wake up as a surgeon, go to the OT, have a packed day. Does the surgeon in you say that I'm done for the day? And when that happens, what does a surgeon goes through? That is one. And what does Mazda go through when you're ending your day rather, and you're just done enough, and you've had massive difficult patients as well, and you've had so much of talking and so much of operating done, and you're just done, and no more patients. So what does the surgeon in you go through? Let's say if there's another person waiting outside when you're done, and what does Mazda as a person feel when there's someone?
I mean, I love my work.
Okay.
So I don't get tired very easily. I have abundant amount of energy to continue working. So I can operate for long hours and still see patients in the OPD and still be chirpy and jovial at the end of the day. Very rarely, unless I've had a complication or if a patient's had a problem related to something, or if you have a stream of patients in the OPD that sometimes just take too much time, at that time you can feel a little bogged down. But that happens very rarely.
Okay.
That is not the rule. I just at the end of every day before I head out, just sit with my feet up on the table and sit for 5-10 minutes and go through my day, go through my surgeries in my head, see if I could have done anything differently, scan through quickly the OPD patients in my head. If I need to read up about something that I'm not particularly familiar with or not sure about, I'll do that. And I go home smiling most days.
Okay. So I've heard this from a lot of doctors, and I have not been able to understand the reason. I'll ask you also that in a profession like this, where it's very easy to be boggled, because where I come from, when I see doctors operating and when I see ailments, I feel pressured. I feel, scared. You see patients day in and out. You operate on massive surgeries. You operate on a brain and a spine. Both are complex. So, what is it, because you love what you do, that, or because the profession, when you start with studying neurosurgery and spine surgery, when you had started, that's the passion that brings you to this level where you are just not having a bad mood because of a patient. So is that the reason? Is your passion the reason, or is your profession the reason?
I mean, it has to be a combination of the two, right? I mean, if you love what you do, you'll find a way to not be bogged down by it.
Yeah.
You just enjoy it. I mean, I enjoy operating every single day.
Yeah.
I enjoy talking to patients. I like to listen to their stories. I'm never abrupt with them. However long they need to take, they need to discuss, they need to talk about stuff. In fact, I ask them more questions because I'm happy to listen to a background score. It sometimes gives me material for the articles that I write.
Right.
And so, I mean, if you really enjoy what you do, you're constantly trying to help people, you really enjoy taking care of people, it gives you joy in trying to help alleviate someone's suffering, then it won't get down to you. But yes, there will be days, like I said, you'll have bad days at work, you'll have complications, you'll have patients not doing as well as you thought they should. You'll have unexpected outcomes. So all of these things will weigh you down, but you have to bounce back the next day and go home with a smile on your face. You don't have an option.
Why do you say you don't have an option?
I mean, you are not going to take your worries back home. Your wife and children at the end of a day want to see you, want to chat with you, want to spend time with you. If you're going to go home brooding, it's not fair to them as well, right?
Sure. Does a surgeon have a social life?
Of course, I have a great social life. I have fantastic friends. I go out every weekend, sometimes during the weekday as well. It's not at all difficult to
Have a social
life. Sometimes you have to give it up. If you have an emergency, you leave whatever social stuff you're doing and go and attend to your work. But you may have to cancel birthdays, you may have to not be able to attend certain things if there's a problem, but it's not very often that it happens.
Correct.
And everybody around you understands that that's the nature of your job. Nobody's really saddened that you've left a party midway. And there's so many parties to go to.
Okay. So what keeps Dr. Mazda fit?
I think I never use the elevator in the hospital. So wherever I go in the hospital, I just climb floors. So that's my work. I don't particularly work out. I just do a little bit of back strengthening exercise every day because I have to practice what I preach.
Yeah.
And apart from that, I don't do any other major physical training, which I should.
Right.
But I just climb a lot of floors, and that's, I think, what keeps me active.
Okay. What is the best food for your brain?
So, all kinds of green leafy vegetables are good. Fish is good.
Yeah.
Nuts, all forms of nuts are good. Blueberries, blackberries are good. If you have a sweet tooth, then stick to dark chocolate.
Okay.
Eggs are good,
Okay.
more or less. That sums it up.
So thank you so much, Dr. Turel, for being here and spending so much time. And I know you've had a busy schedule, but thanks always for supporting, and thanks always for attending to the concerns that I come along with from patients, and grateful, very grateful to have you, as a person who I can fall back to for any kind of questions in healthcare.
No, it's my pleasure entirely. Always happy to help, always happy to spread awareness so that people can take responsibility of their health in their own hands and find the right people to help them solve their problems.
Thank you so much.
My pleasure.
That was a very interesting conversation with Dr. Mazda Turel. Hope you enjoyed listening. If you have any questions, kindly post them in the comment section. Thank you for listening. Until next time, take care.